And we're back. We have Franco Impellizzeri. Franco, this is your first time on. I think a lot of the listeners know who you are, and you're really a legend and really highly regarded. So we're excited to have you on our own podcast. For people that maybe aren't familiar with you, can you tell us what you do and who you are?
Yeah. First of all, thank you very much for having me. Yeah, I'm a, a sports science and medicine researcher. I start my activity in Italy in a private research center. I transitioned to orthopedics for 10 years in Switzerland at the Schultes Clinic. And now since 2018, I'm here in Sydney at the University of Technology, Sydney. And yeah, so I had this mixed experience because I start as a coach. So I transitioned to research in terms of main activity later in my career, let's say after my is. And so I'm saying that because my initial experience shaped a bit how I see research and why I do research, which is even if I'm very focused on methodology, is because I always had the necessity to find practical solutions to problems I had. That's why I start to look at research.
And specifically, what we're going to dive in today is a recent paper that you were a co-author on. It was yourself, Stephen Stovitz, and then Ian Schreier. And this came out as of our recording, I think within the past month or so. And the title is The Risks of Misunderstanding the Term Risk Factor, a Primer with Suggestions to Improve Sports Medicine. And the paper and the topics within it, and I think this just overarching conversation around what are risk factors? How do we define them? How do we use the term appropriately? I think is very important and something we really haven't discussed on this podcast. So I thought this was a great way and a great topic to bring you on to discuss. Can you just touch on you and the other two authors? What really were the goals of writing this piece?
Yeah, actually, there is a nice story behind this article because I started to suggest to write something on risk factors several years ago. And Steven Stovitz and Ian Schreier, who are friends, and basically they are mentoring me in the last years, thought that, well, but people know what risk factors are. I said, no, I don't think so. I think there is a lot of misunderstanding and or abuse, I don't know, of the term. And until, let's say, 1 year ago, some articles start to come out using modifiable risk factor, and I forwarded them, and they start to read and say, yeah, I think you're right. People don't understand what is a risk factor, or conveniently, they prefer not to understand. And so we decided to write this article, and it was interesting the process because one characteristic of my research group is that we don't agree with each other often. Having an intellectual opponent among the authors is a very good way to avoid biases and to keep things balanced. So we took a while to write that article. Basically, we hope we clarify a bit the concept. So this is a bit the the story of this article.
This may come out as we dive further into it, but I'm curious, what topics or subgroups did you all have the most disagreement on or butting of heads about when writing this piece?
Well, one of the disagreements is because when we read papers that contains errors, they are actually more, I don't want to say polite, but more positive. They think that people don't know. While I have a different perspective, I think people know some concepts, but they conveniently prefer not to ignore the real meaning. And the reason, that's my personal opinion, of course, is that nowadays we also as a researcher, we try to often have impact on social media. And this for different reasons. One is, in my opinion, a bit ego-oriented, and others is because actually academia asks us to have an impact. So social media, of course, is a way to have an impact. But when you want to have an impact and you want to, let's say, enter in this environment, you need to use claims, strong words, catchy phrases, things like that. And when you do that, of course, you have to work a bit around the real meaning of things because if you approach things properly, probably you wouldn't have a real impact in terms of reactions from people reading. So one of the disagreement is not about the concepts, but about the reasons why people misunderstand or misrepresent concepts. And this has an impact on the articles, of course, because sometimes I may be a bit more punchy, let's say, and they tend to be more polite. But the problem is that if I want to have an impact and make some concept clear, I need to be punchy, because this is the way you get some visibility. And my goal is to try to explain the danger of playing around with terms and terminology, because there are maybe consequences in the real world based on the words we use, because we are delivering concepts and ideas that may be not really backed up by evidence.
Well, I like your punchy approach, not only in this paper, but in previous. And I think it's very helpful. So I like your side of it. And that's also very admirable that you and your research team, you value and welcome different opinions, maybe with shared goals, but not everyone is in the similar echo chamber, which is healthy.
Yeah, yeah, that's the Ian Schreier wrote a very nice article about consensus, and I recommend people to read it because it's a great article. It was published on the British Journal of Sport Medicine. It is about giving space to dissent was in consensus. So if you think about consensus, normally you see the statements where everyone agrees, and you rarely know why the other portion of people didn't agree. And I think it's important, because the fact that the majority agrees with the statement doesn't mean that the arguments of the minority are weak. If I know what are their arguments, I may even agree with the minority. So all our articles, including this one on risk factor, always play around the concept, which is transparency. Transparency is actually what, in my opinion, can save research. We just need to be transparent. It's not a question of abusing terms and terminology. It's a question to be transparent, what we want to say, what we are doing, and be coherent with the limitations, for example, of our studies. Yeah, so I really enjoy having these debates within our group. I think I learn a lot from the internal debates more than the agreements. So I suggest everyone to try to find people, to surround you with people that don't always agree with you. Otherwise, you create your bubble, and I don't think is healthy in the long term.
Yeah, I think that's a great starting point for this discussion. Specifically to the paper, there's different sections within it. And one of the first points that you'll discuss is this causal versus non-causal mechanisms, or causal versus non-causal associations. Can you elaborate on the differences between these two, causal and non-causal, and maybe some examples of how that may actually look in a rehab or sports medicine setting?
Yeah, absolutely. The problem of the use of the term risk factor lies mainly in this confusion. When we talk about risk factors, we tend to think about the factor that cause the disease or whatever events that we are interested. And I want to say about this that this is normal, and this is how our brain processes informations. So, for example, this is called illusion of causality, meaning that the way our mind evolves over time is by interpreting events that are temporarily close as causal. In the big picture, this bias of our mind is actually helpful from an evolutionary perspective, because if you think, even if we are right only once out of 10 times, that one time can save a life. Imagine thousands of years ago. So it's normal that we tend to associate things causally. The problem is that this is a bias, because we are right just in a very small proportion. So when we transport this approach, this mindset to research and risk factors, it creates a problem. And the problem is that we identify a lot of factors that we think can cause an event, and therefore we want to intervene on these factors. And in the best case scenario, nothing happens. In worst case scenario, we can also introduce some problems, and problems is not necessarily that they are harmful. The problems are also that we waste the resources, and we don't have infinite resources, so we have to focus on the things that really matter. So it's very important to differentiate a causal between a non-causal factor. To change the likelihood of an event, the only way to do that is to intervene on a factor that is a cause of this event. So we need to have, let's say, evidence, which is unfortunately much more than having an association with something, that these factors may be causal before investing time and money and resources on these factors. The problem we have seen is that a lot of papers mention risk factors, and if you look at the interpretation, it's almost always causal. So they are assuming that these associations reflect factors that are causally associated with the event. That may be, but we don't know. We simply don't know. And there is the other side of the coin, because I'm talking about association. So when we find something associated and when we find something not associated, we tend to exclude as a cause. Sorry. The problem is that, for example, confounding can create associations, but can also hide associations. So if you in a study you don't find association, but you haven't control for confounding, you may erroneously exclude that factor as a potential cause because you didn't find an association, while it is or it may be a cause. And so it's not only a question of factors associated with something else, it's also about factors not associated that may be actually a cause.
Can you explain that maybe a little bit further? Of you can have something that's maybe causative of something else, but it doesn't have to be directly associated with that. Is kind of what you're saying?
Yeah. So basically, one of the biggest problem and the reason why we tend to usually say associations is not correlations are not causation is that confounding and confounders are common causes. So you have an exposure, an event, and you have a common cause, something that causes both the exposure and the event. I try to give you an example so it's a bit easier to understand. Let's say that I want to associate the intensity during a match and injuries, and I find a correlation between high intensity activity and injuries. So I may say high intensity is a risk factor, something causing the injury. But it may be possible that both are created, this association is created by a common cause, and the common cause may be playing position. So let's say I talk about soccer, but external midfielders, they tend to run more. So if you have in your court more external midfielders with injuries, these midfielders are characterized by high intensity. And let's say that this position is also at high risk, and not because they run, but because of the position, the technical demanding position. There are maybe more opponents chasing you or this kind of thing. So in a situation like that, is the position, which is the risk, the real risk factor that cause higher injuries, but also cause high intensity running, because this is what you do in that position. So this is an example of playing position being a common cause of the injuries and the high intensity activity. So if you would hypothetically intervene on high intensity activity, you would not intervene on the real cause. To give another example, a bit more clinical, is like PSA. This is more related to prediction, but PSA that is used to understand the risk of prostate cancer is not the cause of prostate cancer. It's just produced by cancer cells. So it's a proxy of the real cause. So if you manipulate the proxy of the real cause, you don't change the likelihood of the event. Okay, so that's the problem of confounding. The confounding normally, also when we study at the university, we talk about confounding as something creating a spurious correlation. But what people don't know is that confounding can also hide correlations. So you may have a causal relation between a factor and an exposure, but the common cause can reduce the effect that you can detect when you analyze the data. And this is the other problem I'm mentioning. It's not only a question of associations, is not correlation, but also non-association, not causation, but also non-association may be causation. So it's a bit technical, I know, but that it is what it is. I'm sorry.
Yeah, that example you used initially of the soccer athlete or the sport of assuming it's the high intensity that's driving the increased risk, whereas it may be the position and these other elements of the technical demands, et cetera, what you're alluding to. How do you then identify if there's these moving variables or multiple variables that you are maybe trying to decide what is the causal factor? How do you differentiate and start to pick those out and select them?
Yeah, that's where things become much more complicated. This is related to the so-called causal inference methods. And causal inference methods, the reason why I like a lot is because you have to declare your causal assumption. So you have to declare the structure of the causal links between various variables and the outcome. So in a situation like the one I mentioned, you want to control for the playing position. So you need to find a way and variables that can allow you in the statistical model to control for the effect of confounding. And this is actually where everything becomes much more complicated. And I see that recently there are actually some good researchers like Matt Tenen that actually has run some studies using causal inference, but there are just very few people that in our area in sport medicine, the best one are Ian Schreier, hands down, and Steve Marshall, for example. They have done a lot in this area, also outside sport science and sport medicine, but they are absolutely great on that. But there is not very well developed, and it requires a lot of expertise and knowledge. But the core of this is that you have to declare in advance all your causal assumptions. So you have to tell me exactly how you think that high intensity is causally associated to events and what are all the factors surrounding the process that can have an effect, can mitigate the effect, can exaggerate the effect, or can hide the effect. So the statistical model is the last part of this approach. The first part is developing this causal model. And this is based on expertise. It's not something, now there are some methods like causal discovery using machine learning, artificial intelligence, all these kind of things. But in the end of the day, also these advanced methods, they just propose something. Understanding whether a factor may be causally associated to something else is reasoning, basically. And people may find this a bit subjective, and actually it is. But what they should consider is that when you have and these are called DAGs. When you have a DAG where these assumptions are explicitly shown graphically, you know exactly what are the causal assumptions of the researcher. So you may disagree, but you have something to disagree with. While normally is a more a black box, you have just an association. You have no idea why this can be causally associated. And the problem is that you may be tempted to give an explanation to any association you find. I used to make an example to some of my students. They present an association and I make up an explanation. And sometimes these explanations make a lot of sense, so you may buy it. But in reality, is a made up explanation. Just I'm trying to give sense to what I have found, and this may be a bias, may generate bias. While if you start at the beginning with your idea, reading the literature, trying to find support with the various links, after what you do with the data is try to see if the data fit these causal assumptions. So a causal inference is a confirmatory approach. I try to confirm with the data my causal assumptions, and it's very transparent. That's why I like it.
The causal associations in sports medicine, you gave like a hypothetical of that soccer-based example, but with something like significant injuries like an ACL rupture or some other big injury, are there more known causal associations that you can kind of touch on to give further examples? And then maybe some ones that are thought of as causative that really is not accurate. Maybe it's just this association that's correlated but not causative.
Yeah, that's a hot topic. I have I discussed a lot about this with my colleague Sofia Nymphius, is a researcher here in Perth. Well, the problem is that the majority of the literature associating, we talk about now injuries, associating something with injuries are just descriptive. They are not causal. And so you can generate a long list of factors that have been found associated with injuries, any kind of injuries. The problem is that we don't know what factors are causally associated, so are the real cause. And it's very unlikely that all these factors associated are a cause. It's very likely that some of these are proxy of the real causes. So I don't want to talk about specific factors because I don't want to generate any trouble, but I'm just trying to provide some help on how to interpret this literature. Every time you see a factor that is simply associated with the outcome, it may be a cause, but it may be not the cause. And this is where the use of the term risk factor is important. Because if we use a risk factor, giving implicitly or explicitly the idea that is a causal factor, we end up with this long list of factors. I have seen a list of more than 50 factors associated with injuries in women and these kind of things. It's very unlikely that all these factors are causally related, which means that I can't, also from a practical perspective, I can't intervene on all these 50 factors. I have to focus on the one where I have more confidence that may be causal. And most of the studies on ACL they are based on studies that are just actually descriptive. Descriptive means that the study that just try to explore associations. And risk factor studies, actually, this is well known in medicine, are the most prone to publication biases, like biomarkers, all these kind of things, because you just run study, you calculate tons of correlations. When you find some, you start to build the paper around these few significant correlations, and they may be significant just because of a type 1 error, so not necessarily real associations. I don't want to be negative, but thinking this way, if the literature would be correct, we would know almost everything about the injuries, because there's plenty of studies showing this is a risk factor, these other risk factors. But still, injuries are still a big problem. They haven't really reduced a lot in the last 10 years. So there's something. So my point is simply that every time you see a factor associated with an injury, not necessarily is a causal relation. And what we are suggesting to authors in our paper is to be clear about whether the factor they are investigating or they are discussing is causal, non-causal, or agnostic. I want to differentiate a bit these 3 points, if you allow me. What we mean by causal is a factor for which we have some evidence that this relation may be causal, for example, using causal inference methods and so on. We define non-causal factors for which there is evidence that they are non-causal. So when we say non-causal factors, we are not saying we don't know. We are just saying factors that we have evidence are non-causal. There may be a proxy or real causes. Or what we suggest is to use a risk marker when it's just we just don't want to pick a side. So we have investigated a factor in the descriptive study. We say we found a risk marker with injuries, and which means it may be causal, it may be not causal. We just simply don't know. So this is the differentiation that we suggested. But the main suggestion is just to be transparent. So we propose some terms to use, but the main point is to be transparent. Just let us know when you write a paper if you are referring to a causal factor or a causal factor, and interpret the data currently. I mean, if you don't know if it's causal factor, you can't suggest, well, we need to change, to modify, intervene on these factors, because you don't know. So how can you suggest me to intervene on factors that we don't know? So, and the same is for the use of the term modifiable. I mean, we had some conversation with people that took it a bit bad, but if you write modifiable risk factor, what are you communicating? If I tell you this is a modifiable risk factor, I'm telling you this can be modified. So I'm implicitly saying that you can modify, maybe you can obtain some effects. So modifiable risk factor reinforce the causal relation. And when you don't know, this is what we suggest, you shouldn't use modifiable risk factor because you are priming people in interpreting in a certain direction. So what we are suggesting is use modifiable only for risk factors for which there is some evidence of causality. That's a bit our suggestion.
Yeah, that tracks, or that makes sense. The modifiable causal risk factor, are there things that you can confidently give as an example in the injury or rehab or sports medicine landscape? Or is it to what you're saying, there's a lot of these risk factors that have been studied, but there's just not a lot of knowns as to these causal risk factors that we can't really say that they're modifiable causal?
Yeah. I mean, it would be, whatever I say would need to be explained much better. So I would prefer not to mention specific risk factors. The only thing is, again, that I say is that the fact that something is classified as a modifiable risk factor doesn't mean that is a causal risk factor. Whether it is a causal risk factor, so it's worth to be modified, depends on how strong is the study on which these factors are based and have been identified. So the problem is that the studies are 99% descriptive, are not causal. For example, maybe it's a bit OT, but there is only one paper from Ian Schreier recently on the training load as a risk factor for injuries, which is actually a very complicated area for two reasons. The exposure to training is both the time at risk and the factor that can increase the injury risk. I try to explain you better. If you sprint 10 times, you will have half of the risk than sprinting 20 times. And this is just basically true mathematically. The more you are exposed to the risk, the higher is the risk. It's like if I drive 1 hour, my risk is lower than if I drive 2 hours. Okay. So the problem with training is that training is both the time during which you are exposed to activities that can increase the injury, because if you sprint, you can have an injury, let's say an hamstring injury. Of course, if you don't sprint, you are not exposed to the event where you can develop the injury. And this is where with training, everything becomes much more complicated because people don't differentiate between these two factors. Because on one side is the time at risk. On the other side, it also generates, let's say, demands and adaptations and damage that can increase the risk or can have an influence on the risk. So the study of Ian Schreier was very, in my opinion, is a great study because they use a causal inference approach called time trial emulation. So they try to emulate the target trial emulation. They try to emulate the trial using observational data with all a series of adjustments and assumptions that are needed. But what they have also tried to differentiate is the increase in the risk just because you are exposing people to a longer duration during these risking activities with increased risk due to the exposure to training. So training as a risk factor and as an exposure. And what they have found is that when the participation increase, the injury risk increase. But this is expected because you are just doing more. But with more training, the more you train, this increase is lower. So you are still increasing the risk training more, but the increase in risk is lower than what you would expect just increasing the time you expose people, which means there is a protective effect. What's the problem here? The problem is that it doesn't give you the answer how much is enough, because basically what this study is saying is that the more you train people, the more robust they become in terms of injury. But training them expose them to a risk because you are exposing them to more activities during which they can have an injury. So how much is enough? It's up to you. It's up to the professionals. So it's a risk balance consideration. It's not possible for a researcher to tell people when this balance is acceptable or not, because it's contextual. It depends on the context. If you are closer to the finals, you may want or may not want to run some risk that you actually may be willing to take when you are far from the finals or things like that. It really depends. So these are the principles that people should think about. So also when we talk about risk factors, even if training can be considered risk factor, besides training is, as I explained you, is a causal risk factor because it's the time at risk. So if you don't train, you don't have, you don't run any risk, of course, which is actually what is done in load management. People say, "Oh, it works." Yeah, of course it works. If you play half of the games, you will have less injuries during the games because you are playing half of the games. So it works. I can tell you, you don't even need to run studies for that. The problem is over time, whether you make people more robust and able to cope with the demands from a performance perspective of the activity and balancing out the risk of injury. So it's a balance.
Yeah, that is somewhat, quite a bit challenging and confusing, I'm sure, for a lot of coaches and rehab providers trying to find that balance to what you're saying of the exposure to the training or to the sport allows for likely positive adaptations and better preparedness for those things. However, those things more exposure to those things can also increase the likelihood. So it is that, like you're saying, the context of what are the situations in which we may want to lean into, we know we need just more and more exposure and we're willing to take the risks. When do we want to pull back? And that's going to be something that's hard to answer in a research study for an individual coach or clinician and athlete working through that in real time.
Yeah. If you think about evidence-based medicine, is based on three pillars. And one of the pillars is the patient values and preferences. And that pillar basically is context dependent and individual. So that's why I think that any intervention should be possibly discussed with the athletes. They are not passive subject of our process. They are an active part. So if we want to do something, we need to share and tell them what are the risks and the potential benefit, and deciding. As a coach, I did this several times. When you were close to the Olympic Games and you have to do something, you say, look, we have just 2 months before the Olympic Games. If we don't do anything, you will be there, but probably not in the top of your physical condition, or otherwise we can risk a bit, and we decide together. So we talk a lot about shared decision. This is an example of when shared decision is needed. People want to have, I understand that, some numbers to decide when is too much, when is too low, when I cut, when I increase the load. That's the reason I don't want to touch today about the acute chronic workload ratio. The reason why it became so popular despite being scientifically weak is that it provides an easy metric that can be used and people could use as an heuristic to decide, it's above 1.5, we have to cut, we have all these kind of things. So the resistance I found when I tried to explain the problem of this ratio was actually that people told me, okay, what do you suggest instead of these ratios? I know I can't suggest anything because I can't suggest a single value that can give you this idea of this, can allow you to understand whether one is at high risk or not. And this is related to the prognostic side of research, developing prognostic models, which is a very difficult area. It's possible, in my opinion, but it's very difficult. And the group of Garrett Bullock, they publish a nice systematic reviews on prognostic models for injuries. And the conclusion was actually expected, is that none of the models developed and proposed in the literature has enough quality to be recommended. I would say that most of them don't even present the model. So you cannot even externally validate the model because you don't have the parameters to reproduce the model. So that's the problem. And this is why we're insisting about methodology, because without the model, we cannot even check whether it's correct or not. And the problem is that this is related to the risk factor. is that people interpret the features in the prediction model as risk factor, causal risk factors, which is the other big mistake when interpreting prognostic models. Because a prognostic model, you don't even need to use a causal factor. The goal is to have a prediction, and you focus on the prediction. Whatever you use to get that prediction doesn't really matter. It may matter, but in some specific scenarios. But overall, a prediction model is just a model that predicts something. The factors in the model are not necessarily causal, and they don't need to be causal, because you can have a great prediction model without using any causal factors. You can use all proxies of the real factors or the causal factors, and it would work.
We've already touched on quite a few reasons for this misunderstanding or misutilization of the term risk factor, or a lack of granularity about what it means or how it's being studied. You, in the paper, also dive into the topic of risk itself and the different definitions that comes with as well. Can you touch on what y'all bring up in the paper as to risk as a term outside of just risk factor, and all the different kind of meanings that can come with as well?
Yeah, because when in our conversations, when we were developing this article, we were trying to think about the reasons why people misunderstand the term risk factor. And we came out with some reason. One is, as I told you, people sometimes conveniently prefer to interpret in a causal way because it's easier to sell their study. That's another one aspect. One reason is because of this causal illusion of causality, so the way we tend to interpret things. And the third reason is the term itself, risk, in the current understanding. Because, and we presented the example, when we say something is risky, we tend to think that something is going to increase the risk of an event. So probably the misinterpretation, excluding, let's say, the on purpose misinterpretation, some are related to the terms themselves. So risk, and when we talk about risky activity, risky factors, is more related to the concept of causality. So risk factor, we think, is almost inevitable that people think about it as a causal factor. That's why you have to, in our opinion, it's better to qualify. If you just leave risk factor, people will interpret it as a causal factor, regardless of the nature of the study. Besides on this, there is a nice research from, what's the name? Noah Haber is working for the Center for Open Science. They show that people tend to interpret also the term association as causal, which means it's not enough to use association instead of risk factor, for example. It helps, but it's not enough, because people will interpret the term association as causal. So if we consider all this, the only solution is to be clear. So when you say risk factor, you say, is a causal risk factor, or I want to investigate the causal risk factor, which automatically is saying that I'm interested in understanding whether this factor is the cause of the event, or I'm just investigating this factor as a risk marker to see if there is an association. How a risk marker can be used is another topic. Can be used to identify potential causal factors, for example, can be used to identify factors that can be used in prediction models, can be used to generate hypotheses, and so on. But normally they cannot generate practical recommendations, even if the majority of the studies showing descriptive factors or risk markers, they tend to provide some recommendations. And this is actually something I really don't like, because if you provide a recommendation, you are actually assuming they are causal factors. They may be, they may be not. And people say, well, but there's no, what's the risk if we say to intervene on something? Well, the risk is something that people in sport tend to underestimate. Wasting time in doing something that is not really useful, and you cut time for something that can be useful, is a risk. Investing resources or spending money in technologies or techniques that are not really helpful is a problem, because the same money, for example, this is something I'm pushing a lot recently. I would prefer to spend money for people than technologies. So having good people, or paying well the people working in with athletes. So there are different kind of risks. A risk is not only having an injury, for example, can be also creating issues within the environment, reducing the quality of the overall approach, also cutting out the ability to discuss within the teams about dissent. This is, we come back to what we discussed at the beginning. The reason, probably, I also published a paper on the Nordic hamstring showing that the evidence is not that strong on Nordic hamstrings. And the reason is because in some conversation I had with some staff, they always show me this meta-analysis. This is the meta-analysis published in the British Journal of Medicine. Yeah, but it's wrong, that meta-analysis. So it doesn't matter if it's published. And so since people told me, oh, yeah, you are saying always is wrong. If you are right, why don't you publish it? I say, well, but the errors are actually basic. So everyone with the minimum knowledge of meta-analysis understand the errors. So they insist, and in the end, we publish the paper. But the point is not to say not to use the Nordic hamstring, of course, because people ask me, would you use that? Yeah, I would. But you wrote that the evidence is not that strong. I say, but doesn't mean that I don't want to use it. It's just that I reduce the expectation. So I'm telling you, yeah, if you use Nordic hamstring, you don't have anything else. It may help. There's some evidence that it may help, but the evidence is also not strong enough to exclude that it doesn't help and can be even worse. So this is the uncertainty. It's up to you to decide what to do. That's, in my opinion, this is the most transparent way to approach the problem. I don't have to claim you can reduce half the injuries. First of all, it doesn't work in that way. And people have implemented, there still are plenty of hamstring injuries, and actually they risk their position because they push a lot. Players didn't like the Nordic hamstrings. I mean, there is uncertainty. We need to acknowledge the uncertainty. Based on the uncertainty, we can make decisions, at least better informed decisions.
Yeah, that level of certainty as a coach or clinician maybe is coming down over time as these conversations occur, where there's less confidence about the robust positive impacts of a certain intervention like the Nordic hamstring curl to what you're expecting. But your reasoning or argument is, for something like the Nordic hamstring curl, you still may utilize it, maybe for a variety of factors, because maybe the implementation of it is there's very little overhead in the sense of the equipment utilization, the time availability, the general kind of physiology of the tissue adaptation. All these other reasons maybe make it so it's an approachable and applicable thing to utilize as an intervention, but you're not hanging your hat on it as a extremely strong reducer of hamstring injuries. Is that kind of an accurate way to kind of conceive some of these things that we once maybe think or thought were really potent in their stimulus from a risk reduction standpoint or injury prevention, but we still may lean to them for general training and rehab because there's still a potential benefit, and the other risks that you're talking about, the time investment, the technology investment, et cetera, maybe aren't that high?
That's exactly what I try to explain, and I'm happy you actually explain much better than me. That's a bit the point. Is not to say don't use this or don't use that. Is to provide information so that you make a proper decision, and it's up to you the decision. That most of the time there's not right or wrong decision. Is just contextual. But this is, if you think this is what happens in medicine almost every day. This is what I learned when I moved to work in orthopedics in a more medical area. There are a lot of decisions that are made based on different information. So you have a diagnostic test, a prognostic model, you speak with the patients, you have all this information, and you make a decision. You don't see one single parameter that you use to drive the decision, which is something I see often in sport. We tend to try to find these magic numbers, magic thresholds, and all these kind of things. There is an uncertainty is part of the job. There's nothing wrong with uncertainty. That's how the world is that we live in an uncertain world. And we just need to be aware of that. And we need to, as a researcher, now I'm talking as a researcher, I need to be transparent and tell you the truth. So I can tell you this is how it can work or it may not work. This is the uncertainty. This is the information I give you as a professional, and you will decide based on this information whether it's convenient or not. As you said, it doesn't require any kind of equipment or these kind of things. It can be easily implemented. That's absolutely fine. But the expectation should be commensurate to the level of evidence. Because if you start to read the papers, I mean, there are meta-analysis saying, oh, this 50%, this 30%, this 80%. If it would be real, we would have solved the problem of injury. We would have half of the injuries than in the past. Of course, now people say, yeah, but now we run more, which is actually a bias, more a cognitive dissonance. But in reality, it's clear that we don't have a great understanding on the causal factors. It's true, it's multifactorial, it's dynamic, nonlinear, all these kind of things. Still, we don't have control on these factors. So we need to be aware when we decide what to do with our athletes. And this is important because if you are doing, for example, a discussion I had about the Nordic hamstring was that, yeah, you have to do something that is eccentric. I said, why are you saying that? Because Nordic hamstring is eccentric. I say, yeah, but no one has compared eccentric with concentric. So we don't know. Maybe it's right, but maybe it's not. So if there is someone else using constraining kind of activities, I wouldn't say it's wrong. Maybe, okay, we don't have the evidence to support the eccentric component of the Nordic hamstring. So it's, again, as I start, and also the reason of this article is about transparency. Let's be honest. Let's tell people how things are, and they make their decision.
It's really enticing as a clinician, especially as a newer clinician, to lean into black and white decisions or numbers or percentages. I think really popular and salient is these percent limb symmetry for ACL return to sport, this 90% number, that it's this magical cutoff that if you're below it or if you're a little bit above it, there's these substantial changes in injury risk reduction or injury prevention. And I've just become more and more skeptical of that notion for a cluster of reasons. But same thing to what you were alluding to earlier about the acute to chronic workload, the ratio of these numbers or these ratios, these percentages. It seems so tangible and it gives a false sense of confidence, which I think is scary for the clinician to think that way and then to portray that over to the patient or athlete, especially if there's another injury and you're giving this sense of confidence that we've hit this number, we've hit this percentage, we've hit these markers, your chance of injury is minimal to none, or there's no way you're going to get injured. However it's framed, it's scary because, to what you're alluding to, it's likely inaccurate, or there's just a much bigger spectrum of kind of allowable, probably markers, and people that hit certain numbers may or may not get injured versus people that don't. And it's just, yeah, it's enticing, but I think a lot of times it's very inaccurate.
Yeah, it's actually a psychological problem. We tend not to deal well with uncertainty. And so we create what I call the illusion of control. So using this threshold, these numbers give us the illusion that we have the process under control, but we don't. So the sooner you realize that you don't have control, and that's normal, because the problem is that people feel uncomfortable to admit that they don't have control on the process because they think in some ways they are confessing they are not doing their job well. But actually, it's, in my opinion, is the way I see is the other way around. I mean, if you claim that you have control, I think you are not doing your job well, because it's not possible to have control in most of these processes. You can have a lot of information coming from the processes. It's like you said, you can have the asymmetry. You can use 90%, 10%, this threshold. If you go back, you will realize that there's no reason to use these thresholds, but that's another topic. But this is the wrong way to use this information. You test someone, you see there is an asymmetry, and this is an information that you adapt to other information. And people say, yeah, but this is the way I use it. No, it's not, because if you use 90% as a criterion, that you are not using in this way. Besides, we published, when I was in Switzerland, we published a paper on the reliability of asymmetry. And asymmetry is one of the less reliable parameters when you test someone. So if you don't trust me, I invite people, if you have some devices, test 2-3 times in the same week your patients, and you measure the asymmetry, and you will see that is very unreliable. So you may have 80 percent of difference, which is below the threshold. So it's good to go back, and maybe the other two is above 10. What do you do in that case? And this is the uncertainty of the measurement, which is again, it's unavoidable, but you have to think about it. So even if it's 7-80%, you have to think, yeah, okay, but there is uncertainty around this number. There is an error, a measurement error. So this 8% may be higher. So the threshold don't really work in that way. There are thresholds that can be used, but it's much more complicated.
Yeah, it's challenging for a clinician to accept that and then in real time discuss that with a patient. And maybe to what you were touching on earlier, it's these culmination of things and this shared decision making that gives clarity to the next steps of, am I ready or are you ready to return to sport? Well, let's have a discussion and look at all of these different things that have gone on in rehab over the course of 3 months, 6 months, 9 months, 12 months, whatever it is. With all these factors put together, these are my general suggestions and recommendations. And this is what I think your readiness is at. What do you think? And it's like you said, the shared decision, you're not hanging your hat on one specific metric or one specific test. You are hopefully gathering useful data and information along the way. You're hearing also the patients and the athletes' reports of readiness and the progression back into sport, but trying to base a decision off of any one metric, a clear timeline, a clear number, a clear percentage, that's probably too limiting and too inaccurate.
Yeah, that's exactly what I think too. And just use the information you have as information to make a decision. Don't use thresholds. You can use threshold, but only if the studies showing these thresholds are very well done. And I can tell you, I don't mention any study done at a level of quality that I would suggest to use. So just do whatever you need to do, measure whatever you need to measure, collect this information and make a decision based on this information without using threshold, but combining the different information and possibly discussing with the others, which is something that I think that's my personal experience. Sometimes we don't do enough. We think about, we cut the players not going to play because we need some load management, and we don't ask the players, and the players may not be so happy, and this may create other problem issues, self-confidence issues, things like that, depending on the sport. So I think it's important to share the decision with the athletes, not only among the staff. That's important. I know it's everyone is saying that, but what I see in the reality is that most of the time the athletes are quite passive in the decision.
You alluded to, with ACL specifically, how many potential associated factors or things that have been studied looking at the probability of a re-injury or that secondary injury or the first injury, but there's an unknown of those being causal factors or non-causal or the risk modifiers or risk markers. For the patient asking the question of, let's say they tore their ACL or they had an injury and they're eventually going to go back to sport, and their question to their rehab provider is, how do I stop this from occurring again? Or how do I limit my likelihood of this occurring again? And maybe you, as the clinician, let's say the ACL example, you are aware of those 50 plus things that you've read in the literature, and you're trying to give some semblance of an accurate answer. Is it just acknowledging we don't really know? There's a variety of things that have been studied that maybe we can classify as risk markers that may or may not be causative. And you're just kind of expressing that true uncertainty to the individual and to the patient. I'm assuming that's your answer, but how does a clinician go about some of these challenging discussions with patients that are asking about risk factors?
Yeah. Before answering, I want to mention the study of Jan Schreier. It's the only one that has actually studied the effect of previous injuries on subsequent future injuries in a proper way, because most of the study are biased by definition. They have introduced immortal time bias, selection bias, and so on. So they published with Hamilton a lot of years ago some papers showing that they used the Cirque du Soleil athletes. They show that when you analyze in the normal way, the way that you see most of the papers, the majority, I would say 90% of our papers, you see that the previous injury increased the risk of a subsequent injury. But when you control for some biases in the proper way, this relation disappears, which means that a previous injury, at least in that court, in that study, under those assumptions, did not increase the risk of a subsequent injury. The fact that they have a higher injury risk is just because they are than others, is because they are more injury prone than others. So if you imagine someone that is more injury prone tend to have more injuries. So of course the time between the injuries is shorter than the other. So what I'm trying to say is that even this idea that the previous injury increased the risk of subsequent injury is something that I wouldn't bet, because all the studies have been done not in the proper way, methodologically speaking. So it may be, but it may be not. Said that, I therefore don't really I think it may increase. I think we cannot exclude that previous injury can increase, but I don't know how much actually can increase more than the baseline risk of an individual. And the other studies, I know I'm mentioning a lot Ian Schreier, but actually, in my opinion, Ian Schreier is one of the best researchers in our area, probably underestimated. But if you read the papers, everything I'm saying was written 10, 20 years ago. So if you want to understand better, my suggestion is try to read the papers of Ian Schreier and Steve Marshall. But basically, if you what I was saying, yeah. So the previous injuries may be just a reflection of being prone to injuries. So you need to control properly, and we don't have this kind of studies. I know Ian actually have insisted with some groups even to reanalyze the data. We are working on something like that to reanalyze the data. This is an important information. We want to understand what we can do. Besides, the fact that you had an injury before, there's nothing you can do. You had it. So it's not a modifiable respect. You just had it. And the only thing you can do is to prepare them better when they come back. So pragmatically speaking, this is the situation. Even if this increases the risk of injury, there's nothing to do. The problem is that, for example, now there are some that tend to increase the time of the rehabilitation, which is okay, but time is not the real criterion, in my opinion. It's what you do in that time that should count. I had this conversation with a colleague of yours, Scott Morrison, as a very wise person, and we discussed a lot about these things. And it's not the question of time; it's a question of what you do in that time. So with the patient, I wouldn't say, look, now you have a higher risk, because I'm not 100% sure they have a higher risk. I would say you may have a higher risk, but if you rehabilitate properly, I cannot exclude that you come back with the same risk as you had before, which means that if you are injury prone, you remain injury prone. And the best predictors, this is actually the only consistent finding in the literature, the best predictor of future injuries is previous injuries. But if previous injury reflect how the propensity to injury, it's quite expected that is the best predictor. So I don't have a real answer on what to say to a patient, because it depends on the patient. It depends on the others that you have in front of you. I would just be honest and say how things are. It's like when I go to a doctor, they give me some pills and they say, let's try this. We test your blood in 2 months and we adjust and we go from there. And if it's acceptable in medicine in other areas, I don't see why this is not acceptable. And after coming back from a rehabilitation after an injury. So we have to educate also our athletes, our patients in some ways.
That injury prone thought process or statement would also be challenging to discuss to a patient. And is that something you'd even recommend discussing or framing? Because one, could that be a self-fulfilling prophecy? Then two, do they lose just a lot of sense of locus of control, of feeling like they have a sense of improving their overall robustness and resilience? If that is true, that it's maybe less likely the previous injury is the main thing, it's the susceptibility to injury, the proneness to injury, trying to tactfully navigate that in a conversation without making the athlete spiral or feel like they don't have a sense of control moving forward. Do you have any thoughts about that challenging dynamic?
Yeah, of course, this is very individual. I can give you some examples. Especially one example of a player that had a lot of injuries. And I discussed with the staff. I said, I think this player is injury prone. There is a reason why he's in this team and not in other teams. There's nothing we can do. So at some point we were discussing about muscle architecture, all these kind of things. The problem was that you don't have time during the season to work on these factors. So to change the architecture, even to try, assuming that it works, but I'm not sure, you need to work a lot, and you don't have the time to work during the season. So we spoke with the player and we said, you had a lot of injuries, you tend to be injury prone. So the only thing we can do is to try to make you more robust. To do that, we need is an attempt. We don't say that you will not have any injury in the future, but we can try to do that. But to do that, this means that we have to focus some work in between the season, because we cannot work in the season, which means it's up to you. I mean, instead of going on holiday and we have to prepare a program, let us know if you want to try it or you don't. And this player say, yeah, I would try. So we provide the program and we organize things. In that situation, we use this to explain the player that to try to reduce the risk of injury, we needed to work more, and this needed to be done outside the season, changing a bit the habits that this player had. So it was again a shared decision. And of course, I'm presenting a positive experience and not a negative one. There are also negative ones. But basically what I'm saying is that the question at that point is a question of communication. It's not even science and nothing. I mean, it's science because there is a communication of science of communication. But in general, it's a question of how to communicate things and concepts to people in a way that they can accept, they can motivate, they cannot. So I don't have a general suggestion other than it depends. But this is normal in any medical area when you have to communicate the patient something. So I and probably this is also what makes some physiotherapists or athletic trainer better than others, because they can establish and they can find a better way to communicate things with people. And so I know I didn't really answer, but I don't have actually.
I appreciate that. And I think that was a helpful example of maybe acknowledging the frequency of their injuries or the history of injuries, not dwelling on that too much, but being realistic with moving forward. We probably need to just build your system up to handle more. And to do that, we need time and effort and energy. You're in the middle of your season. That's challenging. Here's what I propose, or here are my recommendations. These are the things that should be done or that we can try to achieve to help reduce this frequency moving forward. And you're framing it as like positive. We have ideally strategies to attempt, but we're also not giving 100% confidence that this will change, but it's still kind of a positive tilt that you had with that example. So I appreciate that.
Yeah, I have worked for professional teams, and this is often a conversation we had, because the problem is that if you accept that some players are at a higher risk and there's relatively not a lot you can do, you change also the strategy. And the strategy changes from injury prevention to risk mitigation. And this is maybe a bit confusing in terms of terminology, because I'm using this terminology more from an industry perspective. But in general, what I mean is that you try to decrease the consequences of the negative effect. So you know that this is very likely occurring in the future. So you try to anticipate and have a plan B. What do we do to mitigate the consequences of this injury, of a potential injury? And this is a change in the strategy, because in my opinion, it's much more realistic and much more effective, because you move from living in a dream world where you pretend to decrease the risk and the reality sometimes is harsh and you will have an injury with these players, from, okay, what do we do if an injury occur, or how we try to handle the training and the match load in a way that we have the risk in a moment in which is less problematic, things like that. So we change the strategy if we acknowledge that and we know it's going to happen. What do we do? If we are moving in another country and something happened there, we need to intervene as soon as possible. Do we have a personal reference hospital or things like that? So it's a very pragmatic approach, but in especially a high-level professional sport, you need to be pragmatic and not just. As a researcher, sometimes we live in a fictitious world, but the reality of everyday work is much more complicated, and we need to be sometimes also a bit cynic in things.
Let's start to round things out. I'm taking up a lot of your time already, so I appreciate the amount that you've been able to discuss here. To kind of summarize really the big takeaways with this topic as a whole, the main things are to just be very specific with the terminology from a research perspective of what is attempting to be studied. Is it a causal risk factor approach? And what do those methods look like to what you described earlier of how to go about that process? Is it a non-causal risk factor? Are we calling these risk markers to help, one, the research process and get an accurate description of what is or is not showing up? And then that should hopefully lead into helping the day-to-day clinician try to make sense of the literature to have a better impact and understanding of those different terms and how that changes education, decision making, et cetera. And then obviously that bleeds into the patient as well. Anything else, just general summary wise, or kind of key points you want to touch on before we wrap things up, Franco?
Yeah, let's say just to summarize, I say for people writing papers, they need to be clear on the nature of the risk factor, whether it's a causal, non-causal, and this should reflect the nature of the study. So if a prognostic study is a prediction, so the factor is not causal or not necessarily causal, because you don't need to do that. The same if it's a study using causal inference to establish causal, understanding the causes of something. So use the terminology that is in a clear way, in a transparent way, that is aligned to the nature of the study, and the interpretation should be also current with the study. So a descriptive study or a prediction study cannot provide recommendation on how to manipulate the factors that are predictive or associated, because that's wrong. So everything should be coherent and transparent. The problem is when you read the papers, because you should try to understand because the authors often don't say that, and as I said, they are either vague or they play a bit around. So first of all, even if it's written that is a modifiable risk factor, doesn't mean that is a causal risk factor. There is actually a famous meta-analysis published recently on the British, in which the title is modifiable risk factor. But if you read in the methods section, they write, we don't mean by risk factor something causal, but more basically descriptive. Well, but this is confusing because you have modifiable risk factor in the title. So even if they acknowledge that, is confusing, and people may not read each line of the method section. So unfortunately, you have to read everything in a paper, and you need to understand whether the factor is causal, non-causal, or just a predictor. And this is a skill that people that want to remain updated with the literature need to learn over time. Unfortunately, there's no other. Researchers should be more transparent, making the process easier, but people should understand. Understanding whether it's causal, it's easy, because if the study is trying to establish a causal relation, is written in a clear way. You see causal inference methods, they can use potential outcome framework or different framework, but it's clear. When it's not clear is because it's more likely to be a descriptive study. So the summary is researchers should be more transparent and clear, and readers should be smarter and try to understand, read between the lines and try to understand the real nature and the real information that the study can provide.
I think that's a great place to stop. Franco, thank you so much for your time and for your work and for your punchy language and pushback and acceptance on different opinions as a whole. Yeah, keep doing the good work.
Thank you very much. And I hope I help someone at least to understand that uncertainty is normal, accept it, and that's okay. And thank you again for having me. And if there are other questions coming through social media, I would be happy to answer. Okay, thank you very much.
Yep, thank you, Franco.